Hello, I am Dr. Ali AlSalman. Today we'll talk about an important illness, and to know any illness, we need to know the one that matters, the patient. Today we'll talk about Mr. X, a mind story, by me, Dr. Ali AlSalman, a consultant psychiatrist and the head of community psychiatry in Bahrain and the coordinator of Arabian Gulf University in the psychiatric hospital. Who is Mr. X? We need the demographic. We've asked him, can you introduce yourself to us, Mr. X? He's 42 years old, divorced with 2 kids, unemployed, homeless, and living off financial aids. His chief complaint was حرقت روحي عشان أفتك من الله تعبني ما يسكت عني يقول لي موت من سنة. Translated from Arabic, I've burned myself to get rid of Allah, God, because he'd make me tired, because he does not stop talking to me. He's saying to me to die since 1 year. Again, the present history or the history of present illness, we need to put a background. The first part of this background is the demographic data that makes sense and is needed to know the patient. Again, he's 42 years old, divorced with 2 kids, unemployed and homeless, and he's living off financial aid. The second part would be any past history or any family history. So he's suffering from mental illness since 20 years, with 5 previous admissions to the psychiatric or mental hospital, and he was well on medication until then. We start with the things that are before the onset of the episode. Then we start the things that precipitated the episode. 8 months back, he was diagnosed to have diabetes mellitus. He was told that this is because of the medication, due to medication. 6 months back, he stopped the medication, obviously, because of the cost and because of the diabetes mellitus. 5 months back, he became homeless. 5 months back, he said that people are spying and plotting against him, and God's voice increased. The voice was cursing and ordering him to die. He became isolated with poor personal care and hygiene. 1 month back, he had his left toe amputated due to diabetes mellitus, but his interpretation was God cut his toe. 2 days back, he burned himself in a diner and sustained 5% burn, and he was admitted to the psychiatric hospital. Mental state. The history is the longitudinal subjective tool of the doctor. The mental status examination or any examination is the objective at a cut point of time tool to assist the patient, or a cross-sectional way or look at the patient. Mental state examination, appearance, we start from the core of the patient, going outside from the core, from the cells of the patient, from the chromosomes of the patient. How is his age and gender correspond to his looks? His middle age, gender appropriate, but looks older. He's then describing the body. He's an overweight, disheveled. This is describing extensions of the body, disheveled, poor grooming, long hair, beard, and nails. Then things that are on the body, with bandages covering his right arm and both legs. He's wearing multiple layers of torn, untidy clothes with poor hygiene and smell of body odor. He is sitting on the floor, describing the status of the situation. Then we go to the behavior. In behavior, we are describing three main instances. When the patient is alone, while he is coming to you, and while he is sitting with you. He was murmuring to self with pointing fingers, sudden shouts when he was alone. Then, when he is coming to me, he walked with limping, wide-paced gait. He had good eye-to-eye contact. He was easy to develop rapport with, and he was begging for help with sudden turns toward the right side and murmuring. Increased psychomotor activity, fine tremors noted in fingers, and frequent lip smacking and grimacing. Mental state examination. Again, the second part is, the first part is the speech. We have four things to describe the meaning, the voice itself, the articulation, and the grammar or the language or the syntax. His speech was relevant, coherent mostly, with sudden whispers to self. Speech was spontaneous, low in volume, with increased amount but normal rate. He was monotonous and sometimes disheartening. Question number one. What did we get? So, this is the answer that we got from the audience. Acute psychosis, delusion, should be present for 6 months, denoting the chronicity. Delusions, psychotic episode, acute psychosis, yeah, psychosis, psychotic episode with negative symptoms. This is describing both types of symptoms. I would add the social aspect that he suffers from. Second question, which is not true about Mr. X. He's currently suffering from a chronic mental illness. He's currently suffering from a chronic medical illness. He's currently suffering from marital problems. He's currently suffering from financial problems. He's currently suffering from acute medical problems. He's currently suffering from acute mental problems. Chronic mental illness, of course, schizophrenia for 20 years. Medical illness, diabetes, marital problem. We'll see. He's having financial problems, yes. He's living off financial aid and he stopped medication because of the cost. He's currently suffering from acute medical problems. Most of the people answered that. Was it the correct answer? We'll see. He's currently suffering from acute mental problem. Any acute mental problem? Well, he had a chronic one, but the acute one was the exacerbation and the suicide. So, which one is it? The one with 25%, which is marital problem, or 67? Let's show the correct answer. Well, the correct answer is the marital problem because he's currently not suffering from a marital problem because he got divorced. However, the acute medical problem is what? The burn and the complication of diabetes is implicated too. Schizophrenia as an illness. Its story. Let's define it. Well, can we define it from the patient's story. It's a chronic illness. Is it a medical or a physical illness or psychological illness? It's a mental illness that's chronic, deteriorating, and is characterized by psychotic features and negative symptoms. The literal meaning is from Greek schism, to split, friend, the mind, splitting of the mind. Does it make sense? In a way, yes, it's showing the severity, the severe mental illness, and it might signify the splitting from reality, but it does not explain all the symptoms. History. It was there since the beginning of time, but let's talk about the modern. We'll start with the one who first described it in the modern writings or literature, this French gentleman, Benedict Morel, who described it as dementia precoce, which is early dementia. Okay? Then this German gentleman described Emil Kraepelin, who described it as dementia precoce, the Latin word for early dementia. And he gave us something else. He said that as a description for this illness, it's a long-term deteriorating mental illness. In contrast with the second mental illness that he described, which is a cyclic illness characterized either by mania or depression, or depression alone, but cyclic, which is either bipolar or depression. Then this Swiss gentleman, Eugene Bleuler, gave us the name schizophrenia and gave us more description. The four A's: autism, ambivalence, affective flattening, and association loss. Then the one that gave us the best description at that time, which are the first rank symptoms by Kurt Schneider. Kurt Schneider. ABCD: auditory hallucinations, broadcasting of thoughts, controlled thoughts, and delusional perception. These days, we gather experts together and they meet and decide on the common language that we need to diagnose an illness. That are criteria. So this is the DSM-5, Diagnostic and Statistical Manual of Mental Disorders 5. And they say we need two or more of these for 1 month. HNDDD: hallucinations, negative symptoms, delusions, disorganized speech, disorganized or catatonic behavior. And we need to have dysfunction for any disorder. And this dysfunction should be for 6 months. And we need to exclude a significant mood feature or symptoms or cause of the psychosis. And we need to exclude organic or substance cause. Other psychotic disorders, if we did not get global dysfunction, if the dysfunction is exclusive to one delusion and the dysfunction is in this delusion area only, this would be a delusional disorder rather than schizophrenia. If we could not get the 6 months, this would be either a pre-psychotic episode or schizophreniform disorder. If we could not exclude the mood, can be either depression with psychosis, mania with psychosis. Can it be hypomania with psychosis? Of course not. If there is psychosis, it would be mania. Or it can be schizoaffective disorder. we need to exclude organicity and substance related psychosis. Symptoms, they are the positive symptoms, which are added to the normal person: hallucinations, delusions, disorganized speech, disorganized or catatonic behaviors. Negative symptoms that are deducted from the normal, they are taken from the normal person. Affective flattening, allogia, avolition, and hedonia. Sometimes the catatonic features are considered something with the negative because they are losing some mobility and other things. Cognitive symptoms, they are similar to the negative symptoms. The normal are lost. Attention, concentration, planning, problem solving, abstract thinking, and in turn, learning will be impaired. Subtypes, they are out of trend now, but it's good to know them. Paranoid is the one characterized by psychosis, disorganized features that are thoughts or behaviors. Catatonic is the catatonic one, and residual or simple is the one with negative symptoms. Epidemiology, the prevalence is 1%, male to female ratio is 1 to 1, age, usual age is 15 to 35, but there are earlier and later. Earlier usually in men and later in females. Epidemiology, the hereditary part, monozygotic twins usually are like two parents, so 40% in both, and any one first degree relative will increase the probability by 10%. So instead of 1%, like the normal population, they will have 10% of developing schizophrenia. So what's the etiology? Do we know it? Nature or nurture or both? Probably both, but we still don't know for sure. The hereditary part, we've just said, there is a part, there is an etiology in this area. The genetic part, there are multi-genes, and abnormal genes are risk factors. Usually, they are activated during neurodevelopmental age, the early year or years of life. Etiology, again, other factors: head injury, maternal flu, winter birth, cannabinoid use. That's the hypothesis, the pathophysiology. Where did we get these? From the people who abused certain drugs. The people who abused amphetamines, which we know that increases dopamine in the brain, had psychotic features. And the people who abused LSDs, which increases the serotonin, had psychotic features. So probably these are related. And glutamate is something related to both these neurotransmitters, the main excitatory neurotransmitter. So the most important one to know about is the dopamine. It's a direct one. Do we know this? It's the graph showing us the pathways of dopamine in the brain. It originates usually from the midbrain and goes to other target areas. Number one is the nigrostriatum. It goes to the striatum for movement. The second one is mesolimbic. This is the one related to positive symptoms for psychosis. C is the mesocortical. the one that's related, that goes to the frontal cortex, and it's related to the negative and cognitive symptoms. Cuboid from the hypothalamus to the pituitary, and it inhibits the prolactin production. And the fifth, we don't know what does it do. Does it explain schizophrenia? Let's go back to dopamine. Does it explain schizophrenia? Well, increased dopamine in the second pathway, the mesolimbic pathway, causes psychosis. Does increased dopamine explain the negative symptoms? Actually, no. Mesocortical pathway, if it's excited and if the dopamine is increased in this pathway, it will improve negative symptoms. It will improve cognitive features. So, increased dopamine would not explain schizophrenia. It would explain psychosis. But it should be an increased dopamine in one area and decreased in another. What could cause that? That led us to the theory of glutamate. Hyperfunctional NDMA glutamate synapse causes the glutamate to be excited. When glutamate is excited, it affects the dopamine pathway in the second mesolimbic pathway directly, and it causes the dopamine pathway to be excited, and more dopamine will be produced, causing psychosis. However, the effect on the mesocortical pathway is not direct. It's governed by an interneuron. This interneuron is usually these interneurons are inhibitory. When it's excited, it will inhibit the mesocortical pathway, causing the negative symptoms. What about the treatment? What's this? It's electroconvulsive therapy, ECT. What's this? The skull. There is an opening in the skull that's trepanning. It's used in the dark ages, and it was probably helping because it's a shock therapy. The whole idea of this slide is the shock therapy that was used before. What's the one on the left? The one with the white matter that's there? It's camphor. It was used to cause seizures. Insulin was used to induce insulin shock, sometimes seizures as well. It's again a shock therapy. Italy, Ugo Cerletti, and pigs. What does this signify? Oh, Ugo Cerletti, the psychiatrist, was seeing the pigs being slaughtered in Italy, and before getting slaughtered, they were electrocuted, and this caused them to have seizures. So he said, "Oh, we need controlled seizures. Why don't we use electricity to cause these controlled seizures?" And he started the electroconvulsive therapy movement, which was the trend in the 30s. Then what happened in the 30s? Oh, which one? World War II. And who are the most important doctors in wars and afterward? Of course, they are the surgeons. Why do we have a cow and a French flag and two people? The surgeons wanted to cause an artificial hibernation for their patients to promote healing, and they asked for substances that can induce this hibernation. So, one French chemist, used a medication that was being used for cattle, for cows. as a deworming agent, as an antihelminthic agent, which is phenothiazine. And he modified this substance because it's toxic to the human being. After modification, he produced promethazine, Phenergan, an antihistamine that was used and is still being used as a medication that helps people to sleep and stop some extrapyramidal side effects. Hmm. So they felt, oh, this is a good substance, but develop it further. So he did, and he developed the substance further and produced chlorpromazine, which was used widely by surgeons as a pre-op medication and post-op. And because of serendipity, the surgeon that was using it the most was the brother-in-law of Pierre Deniquet, the one on the right, which is a psychiatrist, who is a psychiatrist, and he talked to his boss and Jean Delay and asked him if we can use this medication that my brother-in-law was using for his patients pre-op and after surgery. And they said, well, let's try it. And they tried this medication on 8 patients, and this was the first study, and all the patients improved. And this started the era of antipsychotic medications. Prognosis of schizophrenia. Usually, we consider schizophrenia as one of the mental disorders with the worst prognosis. But there is hope at the end of the tunnel. Good prognosis is 425, intermediate is 50, and poor is 25. The poor prognosis is getting less and less. The good prognosis is increasing, and it's dependent on the early detection and treatment aggressively from the beginning. The good prognosis is acute or late onset, so the exposure to psychosis will be less, and having positive symptoms is better because they are in some way less problematic in treating. Mood symptoms are good prognostic factors, and any type of support. Complications, well, schizophrenia is the third disabling illness, just less than quadriplegia and dementia, and more than paraplegia and blindness. 10% of people with schizophrenia commit suicide. 80% of them have medical comorbidity, double the normal population, even without medication. And 80% of them do smoke. The normal population, 30 to 40, again, more than half. And now the trend of smoking is getting less, so 18% in the general population, but the schizophrenic population remained the same. 10 to 25 years of their life expectancy is lost. Questions? Question where we are dividing the students into two groups, ladies and gentlemen, and this is question number one or number three, but number one for the group. Which is true about schizophrenia? Acute onset is a bad prognostic factor. Schizophrenia is a pure genetic illness. Excessive dopamine fully explains schizophrenia. Schizophrenia is more disabling than paraplegia, and crippling was the first to describe first-rank symptoms. And the correct answer is, let me show you this is the correct answer, which is schizophrenia is more disabling than paraplegia. Question number 4. The duration should not be less than 6 months, risk of which is not true about schizophrenia. The duration should not be less than 6 months. Risk of smoking is lower than the general population. It has some genetic related etiology. Depressed mood is not one of the diagnostic criteria. 25% have good prognosis, which is not true. Risk of smoking is higher rather than lower. Let's see which one is correct. And here we go. Again, a point for the ladies. Number 5. Which is the site responsible for the negative symptoms? The target site. All of them originate from the midbrain, but they go to different target sites. The target site we need to say is, or the one that's responsible for negative symptom is the frontal cortex. That's it. Thank you and hope to see you again